Welcome, dear friends and everyone. This is Dr. Sharad Jaitly from New York. Thank you for watching, learning, and sharing on MuniMeterHealth.com, your favorite website, which is dedicated to educate you about the human heart and its illnesses as we move forward on our two channels, namely the Facebook as well as on the YouTube. I hope you're signed on both. And without any further ado, I want to once again welcome you on MuniMeterHealth.com, specifically so my interns, residents, fellows, and my dearest colleagues and all my friends. Thank you for showing the enthusiastic interest and support in my cause of spreading the education freely to all. Thanks again. Without any further ado, as I always say, let's delve into the state of the matter of the subject being today, the ruptures of the acute myocardial infarction, I call them. The ruptures, which are complications, obviously. When do they occur, and what are the types of ruptures that one encounters during the so these are complications, remember, obviously, of the acute myocardial infarction, but the ruptures occur in at least three major categories. So let's understand the three major categories here. One is the interventricular septum, if you will. Another variety is the free wall rupture. And the third variety is the papillary muscle rupture. So I'll just pull the rupture here so it becomes easier for all of us. And then I draw these lines here to distinguish and contrast, compare and contrast the three. So what is an interventricular rupture? And let's draw a little cartoon here for our sake. And essentially, the interventricular rupture occurs mostly at the base of the septum rather than at the apex. So the incidence is higher here as opposed to the apical. The basal part of the interventricular septum, when it ruptures, is invariably an inferior wall MI, if you will. Whereas here, obviously, it will be the apical MI, which will be anterior wall MI. But this is lesser in incidence, this is more in incidence, just so that you know. It could be a small rupture like a fenestration, it could be a serpiginous rupture which you cannot see so well, but there will be a shunt from left to right. And this is being the left, this being the right, so obviously there will be a shunt here, and that shunt will be able to be seen on an echo, and which we'll talk about in just a second. So basically this is the pathology and this is the incidence. Remember, the incidence is about 1 to 5%. Whether or not you give fibrinolytic therapy the patient has received, still the incidence is about 1 to 5%, and the incidence tends to be a little lower here for interventricular septum if you give fibrinolytic therapy. Whereas with the free wall, regardless whether you give fibrinolytic therapy, the incidence still remains 1 to 5% there also. The papillary muscle rupture incidence is about less than 1%, so make a note of that. Again, papillary muscle rupture, I do want to draw a cartoon here for you guys, so this way we have some conceptualized figure here, for instance, a little schematic, if you will. Now, the two papillary muscles, remember which ones are they? Well, one of them is posterior medial and goes with a chordae tendineae, and another one is anterolateral, goes with a multiple chordae here. And here are your leaflets, the mitral valve leaflets, this being the left ventricle, okay? So the papillary muscle, which is situated in the posterior medial area, tends to rupture more than the anterolateral, and the posterior medial is because of the inferior wall MI again. So remember, inferior wall MI is quite a culprit, if you will. It causes basal septal rupture more often than the apical. Inferior wall causes more papillary muscle rupture than the anterolateral variety, which of course occurs in the anterolateral MI as the name goes. Now we are talking about transection of the papillary muscle during the rupture. The whole papillary muscle just gets transected. But invariably, fortunately I should say, only the tip of the papillary muscle gets ruptured, and as a result this chordae will start to fly and the leaflet will become flail. So you'll have a flail leaflet here, a severe mitral regurgitation as a result, and the patient will go into pulmonary edema. Now, from the duration point of view, say the MI occurred and within 24 hours, so it's within 24 hours is a good time to look at for these complications in all cases. Remember, for all cases, it'll be less than 24 hours. And then, of course, it can occur anywhere between 3 to 5 days, and that's precisely why these patients are being monitored for that long period of time, 3 to 5 days maybe on telemetry or ICU, and on a regular floor they could be walking, ambulating, etc., but they'll still be monitored. Having said that, let's understand quickly what the clinical features are. The clinical features imply here, obviously, there will be a harsh murmur, and that harsh murmur is of the acute VSD variety. So I always call it a VSD murmur, which is related to the left to right shunt. The smaller the shunt, the harsher will be the quality. The larger the shunt, of course, the murmur will be less harsh, but still obviously contributing greatly to the left to right shunt phenomenon. As a result, one also, patient will be in a pulmonary edema, remember that, because they can go into cardiogenic shock as well. And these patients are markedly sick. They are very clammy, cold extremities. They have chest pains. They have shortness of breath, etc., etc. So these are the features of an acute VSD, or interventricular septal rupture, as I call it. The rupture of a free wall will lead into a cardiogenic shock, obviously, but a cardiogenic tamponade picture will also be seen. Here, equalization of pressures. As a result, if somebody has pulsus paradoxus, one should really start to see and suspect free wall rupture in that setting. The clinical features, again, these patients, again, they also have electromechanical dissociation, I call it, because the electrical pulse is present, but there is no mechanical pulse felt peripherally or even in the carotids, etc. In the central region, these patients ultimately go into cardiogenic shock if left untreated. So they must go to the OR immediately to have the free wall rupture repaired. Papillary muscle rupture presents with a soft systolic murmur. Remember that? There is no thrill, by the way. There is no thrill in this setting. There is a thrill present here in the interventricular septal rupture of a VSD quality. Remember, thrill is present, but no thrill is felt in the papillary muscle rupture variety. And it's a soft systolic murmur only, originating from the mitral valve, obviously. Patient will be in pulmonary edema because it's a severe MR that has developed rather acutely, and the left atrium has not had time to compensate. Neither the left ventricle has time to compensate, so the left atrium, left ventricle sizes will be the same, or normal, I should say. They're not dilated like in normal chronic severe MRs we see, but you have an acute, that speaks of a non-compliance left ventricle, and in fact the left ventricle could be very hyperdynamic, etc. And so patient may go into cardiogenic shock and will be hypotensive, may be complaining of chest pain, and of course severe shortness of breath will be present, and they have cold and clammy skin and peripheries. Now let's go to the echocardiographic features. The echocardiographic features, which will be the diagnostic, I would say, and this is very, very important. I always say that, so mark that test to be done for any of these ruptures that have been suspected during the course of the acute MI while in the CCU. The echo clearly shows here a left to right shunt. And then, of course, you'll have the right ventricular pressure overload. So there will be overload of this kind, as well as a volume overload too. But left to right shunt will be present, and you will hear you'll see the color Doppler flow, which is inter-ventricular abnormal flow from left to right. Here one sees the equalization of the diastolic pressures because of the features of cardiac tamponade. So the diastolic pressures in all four chambers will be equalized. So that's one feature. And then, of course, one may also see the layering, I call it, within the pericardium. And those are the clots. In other words, you will see in the pericardium, because obviously the free wall rupture has occurred. The pericardium will contain some clots. So those clots will be seen, and they are layering of the echoes one sees as we move from the myocardium to the pericardial area while you're doing the echo Doppler. Here one sees a flail leaflet in the setting of papillary muscle rupture, a flail mitral valve leaflet that has occurred, and there is a severe MR, and that's a 4+, I would say. And then, of course, you don't have a dilatation of the LA and LV, but you will see the papillary muscle or chordae torn. So there will be a torn papillary muscle or a torn chordae tendineae as well. Now, next test one would have to do will be a Swanganz, I call it, Swanganz catheter, which is originally, I want to give the tributes to the two authors who actually propounded the Swanganz right heart flotation pulmonary artery catheter, if you will. Today it's called the pulmonary artery catheter, but it's the same thing. But I think tribute's sake and for our generation's sake, I think it'll still be known as Swanganz. A lot easier to call. And Swanganz normally is a catheter which is passed into the right ventricle and lodges into the pulmonary wedge area, which is the pulmonary arterial area right by, and that senses the pulmonary capillary wedge. So here the wedge is extremely high, obviously, and one sees a step-up mechanism of the oxygen that will occur. There will be a step-up of the oxygen saturation between the RA and the RV. So the PO2 will go up in this setting here, because obviously this is deoxygenated blood, but then the left to right shunt makes it oxygenated in the right ventricle. So say for our discussion purposes, the right atrial pressure, right atrial oxygen saturation is about 60 here. It'll be 70 to 75 here. So that is a clincher diagnosis via Swanganz catheter as you sample the oxygen saturation levels between right atrium and right ventricle, and so also in pulmonary artery. Swanganz here will show again equalization of the pressures that will be seen, and one also sees the signs of cardiogenic shock. The pulmonary capillary wedge will be very, very high, obviously. Here the wedge again will be extremely high. Here the pulmonary capillary wedges are extremely high. One also sees, in addition, because of the severe MR, one can actually see the CV complexes that are present within the wedge waves, within the pulmonary capillary tracings, wedge tracings, I would say. So in a nutshell, I would just want to say that the treatment will consist of obviously IV fluids cautiously, and then you give pressors if you need to, because obviously the patients are in cardiogenic shock. You end up giving intra-aortic balloon pumps in these patients, because that may be indicated in all three settings where you'll be able to stabilize this patient till the patient goes to the cath lab. And invariably, remember, they have extensive multi-vessel disease in all these three ruptures. So it's not just like one vessel, which is the culprit lesion we always call in the MI setting, but there might be 2 or 3 other vessels which may be involved. So obviously then these patients go for repair as well as for CABG. So mind you, these patients are very, very sick to begin with. They're in cardiogenic shock. They need to be stabilized before they can go to the cath lab. Intra-aortic balloon bumps are life-saving in this setting, and they can be all done in the cath lab. The patient's moved out from ICU settings straight into cath lab and then onwards to go for CABG, as well as for revascularization, as well as for a repair of the interventricular septum here, or repair of the free wall, if you will, or repair of the papillary muscle and replacement of the valve totally. The mitral valve leaflet is repaired here and or replaced. So in a nutshell, I've tried to cover it in a very short video here. I know it's a very complicated subject, but very important subject, because the complications, I call them the rupture of the acute myocardial infarction, and it's listed under complications in my video directory. So just so that you know that you'll be able to find it when you have to review it again. And please spread the knowledge freely to all your students, residents, and fellows. Dear colleagues, I thank you again. And hopefully, even for the general masses, you have been able to learn a great deal out of this as well, and certainly helps both for the patients and family. Again, the founding theme of my MuniMeterHealth.com is patient education and medical education together. If we can combine that, the clinical outcomes will certainly improve, and I think that needs to be stressed, and that's what the uniqueness about my MuniMeterHealth.com website is. I thank you again for your interest and continued support. Please keep associated with us and spread the word. Until then, so long. This is Dr. Jaitly. Bye.